Thank you very much indeed for asking me to be here. It's always a great pleasure and privilege to be able to come and talk to groups of patients and their family members and other carers. I was asked particularly this time to spend quite a bit of time just filling in a lot of the background about CLL, trying to unpack for you some of the terminology, some of the jargon we use. Hopefully that's going to be helpful. Both talks before and after lunch, I'm planning to speak for around 30-35 minutes, and so the rest of that time is all devoted to you asking questions. I'm quite happy for you to interrupt me if you feel desperate. I'm also quite happy for you to write questions on pieces of paper. I've already received some, and I'll try and incorporate those answers as I go along. But you know, if people have a burning question, please just raise your hand and try and attract my attention, because I'm happy to stop and answer something. Right, so I was going to start just with some very broad sweep overviews about blood cancers, because I think you know, there's a lot of ignorance out there, even amongst doctors actually. I was speaking to GPs recently, and it was surprising how they didn't appreciate how common blood cancers are if you put them all together. So although the individual conditions may be relatively rare, blood cancers altogether represent 38,000 cases a year, and are the 5th commonest cancer after the top ones that everybody knows about, like breast, lung, prostate and bowel. And we don't really get that profile, I think, in the media or in government. So as David said, collectively working together as a blood cancer group may have more traction in terms of lobbying. It's also the 3rd biggest cancer killer in the UK, and there are nearly 250,000 people in the UK living with a blood cancer, because a lot of patients have conditions like CLL where they will live for many years, if not decades, with the disease. And although it's the commonest cancer that we see in children, it is still the case that this is more a disease of older of people, and the median age overall in blood cancers is about 70, 71. So not dissimilar to that we see in CLL. The way that we classify these blood cancers is using something called the WHO, the World Health Organization classification. It's like a dictionary. It defines all the different diseases, and I think you'll probably be surprised to know that there are more than 100 different types of blood cancer. So when your doctor you see in the clinic looks a bit mystified about some new information, remember that they're probably treating all 100. They won't be seeing all of these patients, I'm sure, because some of those conditions are very rare. But it's a very broad scope, and some of those clinicians will also be covering non-malignant haematology. So it's a big area. So some of them may not have picked up the latest paper in the way that you might have done when you're screening the internet. These cancers are divided really into the immature and mature. By that, it's broadly acute and chronic. So the acute leukemias would be immature blood cancers, and something like CLL is a mature blood cancer. It's then split according to what type of cell the cancer is derived from, and broadly again it's myeloid, which are the ones that lead to neutrophils, for example. I'm sure you've heard of those, and the lymphoid are split into those, and I'll show you that. And then within any of the disease types, so within any of these 100 disease types, there are other factors that we look at that define different prognostic groups. So it's getting very complicated now, and every week we're learning new information, genomic information particularly, that's looking at DNA in these tumours and working out how that influences their growth. And although there are some well-established therapies that we still use, there are drugs that we've been using for more than 50 years that are still highly effective, and we know them very well, and we know their side effects. We've got a really large and ever-increasing number of new treatments that are coming along at the moment, and those, of course, bring with them new and unexpected toxic effects or side effects. and also there are potential drug interactions that we've not seen with some of the other drugs that we've used. So some of the new drugs you can't have with other treatments, or it's not safe to do so. So this is very challenging. It's challenging for you as patients and your carers, but it's also very challenging for the clinical teams. And I just wanted to sort of highlight that, because I think people expect the doctors sometimes to be super experts in absolutely everything, but as I said, the scope is huge, and that's why some people have the advantage, really, as I do, of being able to specialise in particular areas. But that's not the case for everybody. So where does CLL come from? This is a very simplified schema, really, of what happens in the development of blood cells. And we start with something called a stem cell, which resides in the bone marrow and is responsible for generating all the cell types that we see in the blood. And this is a very busy factory that's taking place. And the principles are really that these cells divide into different cell types, and then over time they become more mature until they're ready to do their proper function, which is when they're released into the blood. And so we have red cells and platelets, which I haven't shown here. These are just the white blood cell types. And the white blood cell types are really important because they fight infection, essentially. So that is it's the battleground for dealing with any invaders, whether they're viruses or bacteria or other things. And there are a number of different types of white blood cells. So it's a bit like an army, where you have lots of different divisions, a tank regiment, a parachute regiment, whatever. They all have slightly different roles, but they all work in a very well orchestrated way to deal with infection. So all the components are important. I've just put the myeloid stem cell there, but the cell you've probably heard most about is the neutrophil. I heard David mention about neutropenia, so you're all very aware of how important the neutrophils are, particularly at fighting bacterial infections. And then you have the lymphoid cells, and these are split broadly into B, T, and something called a natural killer cell. And it's from this B lymphoid cell that the CLL is derived. And so this starts as a baby cell. It goes through a number of processes of maturation until it's fully mature. And CLL comes from a close to mature B-cell lymphocyte. And the role of a mature B-cell is to produce antibodies. And these are proteins in the blood which fight infection, and they're very specific for fighting a particular infection. And so CLL is a chronic leukemia that's derived from this particular cell type. And so that's why people are often looking at your lymphocyte counts, and they're interested also in the neutrophil counts and other things. So that's just a simple way of showing how that's derived. But once the mature B cell has, if you like, come off, that events happen which drive it to being a CLL cell rather than a normal B cell. And this CLL cell doesn't function properly. It doesn't function as well as the B cell, and it's no longer controlled by the same mechanisms that control the numbers of cells that are in the body. So astonishingly, this is a huge factory, as I said, producing hundreds of thousands of cells every day, and yet that's tightly controlled so that you always have the right number circulating in the blood, or should do. But that control is lost when a cell becomes a leukemia cell.
Can I just ask, do we have any idea why that happens?
Yes, some. I didn't put the pathogenesis of CLL slide in because it's quite complicated, because it's multiple hits. So there are multiple events that occur, but very simply, almost certainly there's some sort of predisposition which makes that cell more likely to undergo change. You then have some events that happen when it interacts with the environment that it's surrounded by. So we think that the antigen, which is what this cell normally responds to, an antigen is a germ, if you like, usually, is then very much involved in driving the disease. And then there's acquisition of some genetic changes, so some genetic faults, and I will mention some of those, that then drive it further, and those can evolve over time. But it's complex, but we do understand quite a lot of the events that take place. We don't know why they occur in some people and not others, because actually the rate at which these cells are being produced, you'd expect more faulty cells to arise. You'd expect more people to get leukemia, for example, than do. So we're actually quite good at controlling that within the mechanisms. So CLL then is the commonest of the leukemias that we see in Western countries. It becomes less and less common as you move eastwards. So as you move through Asia to the Far East, it becomes much less common. And there are about 4,000 new patients per year. And one of the questions I had was, how many patients are there in London? Well, just roughly trying to work it out, there are probably about 4,000 patients in London who have CLL, because of course the incidence is very different from what we'd call the prevalence. The prevalence is how many people there are actually with the disease. The incidence is how many new cases there are each year. And because people live so long and so well with CLL, there are actually far more people who have the disease than there are who are diagnosed with it each year. You know, so if people died within a year of diagnosis, the 4,000 would match the prevalence, but as it is, the prevalence is much, much higher. So there are probably about 4,000 patients in London. As I mentioned, there is a familial risk, so there's some sort of inherited predisposition to this, but because it's rare, you know, this isn't something we would screen for like BRCA mutations in breast cancer. The median age, as I said, is not young, it's 72, and it's commoner in males and in females. But importantly, the diagnosis is usually made simply on an incidental finding in people who are entirely well, have had a blood count for another reason, often because they're having a well person check, or they're having an insurance or employment checks, and they get a routine blood count which shows some abnormalities. And the course is highly variable, so it's very difficult to describe a typical patient with CLL because the range is so huge. But this is just showing what these cells look like in the blood. And they do look similar to, but distinctly different from normal cells. But the way we are able to make the diagnosis clearly is that these cells express a number of proteins, both on the surface and in the cell itself, that we can detect using some fancy kit. And in fact, we're so good at detecting these cells now, we can detect them down to about a level of 1 in 10 to the 6, which is 1 in 10,000 cells. We can tell that there's one CLL cell there in amongst 10,000 normal B cells. So it's a very sensitive method. It's like a barcode. So, you know, when you're getting your stuff through the supermarket, the barcode can tell the difference between which type of butter you've bought. Well, this is the same. This barcode can tell the difference between a CLL cell and a normal B lymphocyte and another abnormal B lymphocyte, or a T cell. So it's a very sensitive and very accurate method for picking up, which is why we can diagnose it very easily in people who are otherwise entirely well. And in terms of this barcode business, I wanted to just mention monoclonal B cell lymphocytosis here, because some of you may have this condition or have been told about it. And it was some years ago, in the early 2000s, that it was noted that using this very sensitive method, if you just looked at normal blood samples from people who've come up to the hospital for something else, anonymized blood samples, you could actually pick up these CLL-like cells in their blood in about 3% or so of individuals who clearly don't have any disease. And so that led to more work being done and being incorporated into the 2008 IWCLL classification and into the WHO, that there was a condition called a monoclonal B cell lymphocytosis, where you could detect low numbers of these abnormal B cells, if you like, that were just like CLL cells, but they were such a low level that we wouldn't call it leukemia. So it's, if you like, it's potentially a pre-leukemic condition, possibly, but in some it might just be a normal finding if it's very, very low and it never comes to anything. But it's been an important finding, I think, because So this just shows, how frequently it occurs. These are very small percentages, so we're down here sort of 3 or 4. It occurs more commonly as people get older, and it is more common in males than in females. So it follows the same sort of pattern as CLL. It's analogous to what we see in myeloma. There's a sort of pre-myeloma condition called MGUS, which is where they have a level of protein, and this does the same. It goes up with age. But this is not a disease, and this is helpful because I sometimes get people sent to me and they actually have monoclonal B cell lymphocytosis. They don't have CLL. And that's good for them because they don't have to declare that as a leukemia on insurance and travel and all the other things that might interfere with their normal life. And so a threshold's been set. You have to have a certain number of these in the blood before you call it CLL. And so this may come up in discussion at some point for some people. But even if it is CLL, if that threshold is exceeded, most patients are still asymptomatic at the time they're diagnosed, which means they feel perfectly well. They often, after the diagnosis, don't feel so well because suddenly all those aches and pains and anxieties and tiredness and have got a reason. And I think people often, by the time they get to see the specialist, are saying, "Oh well, yes, I've really been feeling very tired for a long time." Whereas when they went to initially to get the test done, they were fine. So and it is the case, of course, that people will then attribute almost anything that happens, and the GPs will do the same, to the CLL. Well, you've got a sore knee, it's CLL. So actually 99 times out of 100 it isn't anything to do with the CLL at all, and so it's important to remember that people with CLL can get other things that are totally unrelated. The clinical features largely rest around the fact that, as I said, these abnormal B cells don't do their job properly. Their normal job would be to fight infection, and if they're not working properly, then there is a difficulty with handling infection. And infection is still one of the most important aspects of life with CLL, if you like, and managing that well can make a big difference to the whole quality of life throughout the disease. And the other thing is something we call autoimmunity, and this is when the immune function misbehaves. So instead of just reacting against foreign invaders like germs, it suddenly decides to have the same sort of reaction against one of your own cells. And typically in CLL, these are cells of the blood. So sometimes antibodies will be produced, actually not by the CLL cells, but by normal B cells, but under the sort of influence of the CLL, which attack red cells or platelets and cause those numbers to become low. And that needs to be managed slightly differently from the problems with the CLL itself. So these are the two things with the immune. And then, of course, these cells get into the tissues. You won't recognise this, but this is a bone marrow. It's one I'm sure many people in this room have had this sample taken from them. That's what it looks like down the microscope. Normally, we would expect to see all sorts of different cells in here and lots of spaces. And when you see it packed like that, that means there's a lot of CLL in that bone marrow, and that's a lymph node in someone, under the arm in someone. So as this gets packed out, the problem really becomes one of not being able to have room, if you like, to go on making normal blood cells. And that's often the main reason why people require treatment, is because they're no longer making normal blood cells at the rate and level that they should be. So just another list of sort of facts about CLL, really. One is this issue about CLL and SLL, because some people will have a diagnosis of small lymphocytic lymphoma because they have presented with a lymph node, they've had a lymph node biopsy, and the pathology report says SLL, small lymphocytic lymphoma. And it's the same disease as CLL. The cells are identical. biologically, genetically, they're just detected in a different place. So most patients with SLL, even if they don't have a lot of lymphocytes in the blood, will nearly always have those same lymphocytes in the bone marrow if you look. And usually over time they do start to go up in levels in the blood. But the two are the same, and actually they're managed in exactly the same way. So the treatments are the same for these two conditions. But I think I see patients, and there's often been a lot of confusion generated over the difference between these two. About a third of patients who are diagnosed may never require any treatment. So it's not even just not requiring treatment immediately. They will never require treatment and die from something totally unrelated to the CLL without ever having been troubled by the CLL. Other than by the anxiety of having that diagnosis. But it is important to remember that because these B cells are faulty, infection's a risk even in patients who haven't had any treatment. So it's not a huge risk, but it is still there. And there are things that, and I'll mention them, that can be done to sort of mitigate that risk. Progressions associated with, sometimes increasing lymph nodes or spleen, and sometimes with symptoms, not always. Sometimes people will remain entirely well, but the disease will obviously be progressing because of the changes that you see in the blood. And the treatment requirement is based on a very clear set of criteria that were developed both by the International Working Group, and also we have them in the British guidelines. And that's important because I think one thing that does seem to happen, in my experience, is people get treated often earlier than they really need to be treated. And if anything, people get more treatment rather than less treatment, more treatment than they need rather than appropriately treated. And it's because it's easier. It's like anything, isn't it? It's easier to give somebody treatment than to explain why you're not going to give them treatment. And particularly younger patients, I think, there seems to be a sense that you've got to get on with it earlier if you've got a younger patient. But there's no biological reason for that or clinical reason for that. It's very important that these criteria are followed, actually. And the natural history is one of remissions and relapses, which can take place over years or decades. I have plenty of patients now that I've been following for more than a decade who have just had one treatment. So they've gone on in remission for 12, 13 years after a single treatment. So, we are now seeing that emerge with the better therapies that we have. So they may never require another treatment. We have to follow that. Nevertheless, you would still be usually told at a first consultation that this is not a curable type of leukemia. But, I put that in inverted commas because it depends what you define cure as meaning. In one sense, cure can be if somebody dies from something else, not from their CLL. Operationally, they've been cured of the CLL. They've not when I say I've got patients who have had treatments and they're still in remission 12, 13 years later, then they may well die from something, from a heart attack or from another cancer. At that point, effectively, they've been cured from the CLL. They've had one treatment and they've never had to have any further intervention. So it's a little bit around that. And I think also we have a lot of incurable conditions like hypertension, diabetes, that are very well managed over a long period of time with appropriate therapy. And, we're really reaching a similar situation in CLL where we've got so many treatments now that can be given that are effective and can be given sequentially, that over time we can probably manage this disease over the lifetime of many patients. So, I think it would still be said to be incurable, but actually I think that's got to be seen in the context of how we manage the disease so effectively now. So staging in CLL. We use a very simple staging system. It's the European one, developed in the 1970s actually. Stage A, B and C. It's just based on how much disease you can actually find when you examine a patient. So this isn't based on CT scans. CT not necessary in CLL to stage the disease. So it's based on how many, so if you can feel lymph nodes in the neck and under the arm and in the groin, that would be 3 areas. And then the stage C, which is the most advanced stage, is based on how poor the bone marrow function now is. Are these cells being produced, the normal blood cells, the red blood cells and the platelets being produced in the right numbers by the bone marrow, or is the bone marrow struggling to do so? And for that reason, you've got to be sure that you've ruled out other reasons. Quite often, patients with CLL will be anemic for another reason. And it's really important that that's established and not necessarily automatically attributed to the CLL. And one of the reasons can be this autoimmune disease, which I mentioned, that can damage red blood cells and also platelets. So that's the staging. And what about prognosis? People are always very interested to know about prognosis, and I can understand that. You're diagnosed with a leukemia, you feel perfectly well. You want to know what your likely outcome is going to be. And unfortunately, we can't tell that on an individual person-to-person basis. We can't say you're going to need treatment in 8.5 years' time. But we do have population data that's been collected using a variety of different factors that give some sort of guidance, but then none of these things are foolproof. But prognosis being, what's going to happen to me? Am I going to need treatment? When am I going to need treatment? Am I going to die from this disease? Those are the sort of things that we put in prognosis. And there are so many factors which influence that. There are, very easily measurable factors, just like someone's age, whether they're male or female. I have to tell you that women do very much better with this disease. It doesn't come as a great surprise to me, but other people seem to find that astonishing. But it's very consistent finding. And, if people have got other illnesses, and I'll come back to that, do have an impact. Largely historically in our ability to give patients who've got other illnesses effective treatment. And then there are factors related to the disease itself, like the stage, which I've just shown you, and that's still important, even though it's just a clinical assessment. You don't need anything other than to have examined a patient and to have checked their blood count. No fancy CT scans or bone marrows are required to stage the disease, and that's still an independently important measurement. And then there are various biological markers, and these are the ones I'll try and explain to you. And then there are treatment factors. So, for example, if somebody's already had some treatment, how they responded to that treatment can be quite important in terms of predicting outcome, although that's becoming less so now because we have new treatments. And some of the new treatments work where the old treatments didn't. So when only one treatment was available and it didn't work, then obviously the outlook was not good. But now we have alternatives that can be used. And also the response to the treatment is also how well tolerated that treatment is. Can people actually take the treatment that you want to give? So when I say clinical utility, that's really saying, how can that information help us? What sort of things, information does it give us which maybe we be able to pass on to you, like predicting whether you'll need treatment, when that treatment might be needed, guiding what type of treatment you might be advised to receive, and predicting the outcome following that treatment. I wish we could answer all these questions perfectly for each person who comes into the room. We can't, but we can give some information about these, all of these parameters, and including predicting survival. And we do now have a prognostic index. You may not be aware, but a lot of the lymphomas and myeloma and others have had prognostic indexes for a long time. And we've had lots of prognostic factors in CLL, but we've never developed an index. And I'm going to show you how some of the factors that have fed into that. Now, ignore all the fancy science on this slide. It's really just to remind me to tell you about Immunoglobulin V gene mutations, because everybody talks about mutated or unmutated CLL. And the important thing here is to know that this is a normal process. It's part of what the B lymphocyte goes through as it grows up, if you like. It's maturing. I sometimes describe it, there's no good analogy as whether or not the cell has gone through puberty. And pre-pubertal cells, those that are unmutated, are rather less well behaved than the more mature post-pubertal cell, if you like. And it's really just a mechanism within the B cell. This gene is really important. This is the gene that constructs the antibodies that fight infection. And in order to be able to construct a specific antibody that will react against a whole range of infections, you think of how many different types of flu there are, or how many different types of bacteria there are. Well, you have to have an antibody that will fight each one of those infections very specifically, very precisely. And this process of hypermutation allows the cell to be very precise and accurate and do its job well in terms of producing specific antibodies. So exposure to antigen is the germ, if you like, and this is where you get this affinity for the antigen. You get a better way of reacting to it because of the mutation. So what we see is that patients who have the mutated form have a better survival than those who have unmutated. And as I said, it's to do with how functional that cell is. So how does it make a difference? Now, you saw it's two times as common in men, so I tend to go for male type illustrations. I'm sure that's the sort of thing Donald Trump would say, isn't it? I should better be careful about making gender assignments. But no analogy is particularly good. But this one suggests, that if you've got a mutated CLL, it tends to be a slower growing disease. This is the group of patients who may never require treatment. And they do respond very well to treatment if it's delivered, and we know that particularly for FCR. And less likely to develop some of the other more damaging genetic change. And then I'll come on to talk about mutations that are actually important faults rather than this, which is a normal process. And then the unmutated, it usually is a faster paced disease. So you're behind the wheel of a car that can get to 0 to 60 in however many seconds. And these patients will usually need treatment, but they still respond very well to the therapy. And more so now, I think, with some of the newer drugs that we're using as well, which perhaps target this group of patients even more effectively. So, but with the current treatments we use, patients with mutated are more likely to relapse and require another treatment. But as I've said, with a lot of treatments to choose from now, that may be less important. So now we go on to the other types of mutation, and we're finding now that there are just lots and lots of genetic damage that's taking place in CLL. We just weren't able to discover it before because we didn't have the sensitive enough methods. But this is just looking at chromosomes. They're not coloured helpfully like this when they're in the real person. This is just a schema. But essentially, there are 22 pairs of chromosomes and then the gender chromosomes, which are X and Y. And the one that's important, obviously, here is 17. And you'll have heard about chromosome 17. And each of the pairs of chromosomes has a long arm and a short arm, and we call the long arm Q and the short arm P. So when we talk about 17p deletion, we're talking about a loss of the short arm of this chromosome. So it's just disappeared. That's a fault. It should be there, and it isn't. And that's what 17p deletion is. And we usually detect this using a methodology called FISH. And the fluorescent in situ hybridization is just a very long way of saying fish, where we have a probe that shows up as a bright colour under a fluorescent microscope. And as you saw, there should be 2 copies there of any gene or any bit of chromosome. And when there's only 1 copy, we know that that's been lost, one has been lost. So we look for the number of dots. Some cells may have no dots at all, in which case they've lost both. Some may only have 1 loss. And historically, we've looked at this for particular types of, so trisomy 12 is when you have 3 copies of the gene. So then you'll see 3 dots when you should only see 2. So we've used these. Of course, there are now about more than 50. So this was, around 5 we used to look at, and there are now more than 50 gene mutations that are probably important in CLL, although some of them occur really, really rarely. And none of these genetic faults are particularly common. The commonest of them only occur in about 15 to 20% of patients. So it's not like some of the genetic changes that take place in other leukemias or lymphomas where virtually all the patients will have the abnormal changes. So the other thing that can happen to the gene, so here's the gene that resides on this short arm of chromosome 17, and it's called TP53, and you'll have heard maybe of that as well. And that's just saying that this is the actual gene that lives on that bit of chromosome. There are lots and lots of genes that are here, but that's the important one because this is a tumor suppressor gene. It's involved in repairing DNA and getting people out of trouble. And so what can happen there is it can be lost, as I showed you on the other slide. So we've just lost it altogether. It can be lost from one or both of the paired chromosomes. But the other thing that can happen is that it can undergo a mutation. So it becomes faulty. So this is a different sort of mutation. Here we're talking about abnormal mutations. And when it's faulty, it may be there, so you can see it. So your FISH test would be normal, for example, because it's present, but it doesn't work because it's mutated and it's no longer functional. So the net effect is the same, whether it's present and faulty or absent, it's not working. And when that gene isn't working, then a number of drugs that we use, for example, don't work very well because they are relying on an intact pathway that involves this gene and this protein. And if that pathway isn't functioning properly, then these drugs can't kill the cell in the way that they would want to. And that's why this is such an important marker in CLL, because if it's there in sufficient number of cells, it does identify patients who probably won't do as well with some of the standard treatments that we use, and therefore we can select that out in advance of giving treatment that may not work well and give an alternative treatment that will work better. And that's the sort of information for us as clinicians and for you as patients is really important because it helps us choose the best treatment that's going to get the best results and not sort of waste time using drugs that might not work very well. Unfortunately, there are patients where those drugs still don't work very well and they didn't have this abnormality, and we haven't yet necessarily found a way of identifying them in advance. And I'll come back to that when I'm talking about treatment. So this is the CLIPI, the CLL IPI. And it's based on a lot of data, mainly from trials, including our own trials in the UK. And they've really come up with these 5 important ones. So TP53, whether it's deleted or mutated, as I've shown you. IVGH, this is the mutational status of the immunoglobulin gene. And then this is just a serum marker of disease bulk, really. And then clinical stage, still there, and older age. And it's come down to just these 5 quite important factors that will predict whether patients will do very well indeed, which is this green curve, or do less well. And actually the ones who do really less well, and you have to remember that this is based on historical data. So it's based on what we were doing then, not what we're doing now. And so although outcome here was very poor for those with TP53 abnormalities, that's going to be not the case if we reconstruct this in 10 years' time when we're reflecting then the outcome with novel treatments that do work in this subset. So a lot of it is around how effective the treatment is. So early stage CLL, I'm going to talk mainly about the treatment in the second session, but just a few things to say. You know, a lot of you will be told, you'll go into a clinic and somebody will say, oh yeah, the GP sent this blood count, you've got leukemia. You know, does anybody hear anything after that? I suspect not. People are in shock. It's a huge body blow. Most people aren't aware that there are, you know, more than 40 different types of leukemia. This is just one of them. But you have a picture in your mind of what having leukemia might mean. And it's not usually a good picture. So, and then in the next sentence, the next thing you hear after a bit of something else the doctor says, and we're not going to give you any treatment. And somehow you're left and, you know, we'll see you in 6 months, bye-bye. And you're ushered out the door. If you're lucky, you might get a session with the clinical nurse specialist and some patient information and things, which you should do, actually. But nevertheless, you go away with these two things ringing in your mind. I've got leukemia, and they're not going to give me any treatment. And it's incurable, because that's sometimes also the other bit of information. I mean, that's devastating. I mean, I would be devastated if I went into a consultation and heard that information. So it's very difficult, because all of that is true, but it's just that it has to be set in the right sort of context. Watch and wait is what we loosely refer to as not giving treatment at the time the diagnosis is made. And it was based historically on a trial done in the 1980s, actually, 90s, and has been confirmed, if you like, even for those patients who would fall into that higher risk IPI group. That giving treatment straight away is of no advantage. And in fact, it's probably a disadvantage, because you're exposing cells to drugs, perhaps encouraging resistance to drugs at a time when it's not necessary to give treatment. So I think, you know, although it's difficult to hear that no treatment is going to be offered, that is actually the right answer. And for many people, it will always be the right answer. They will never require treatment. And for others, it may be years or decades before they do. And this is a difficult time, and I've got another slide on this, but you know, the key thing here is that people should be encouraged to just follow a normal lifestyle. Yes?
Do consultants ever get training about the impact of those three statements together? all the friends I know that have CLL, that's what they always say. Yeah. You've got leukemia, it's incurable, you're not getting any treatment. And what I've also said, you don't hear much, and then you go away and I've got an incurable cancer and they can't do anything about it.
Yeah, yeah.
And hopefully then you pick up leaflets and it gets better.
Yeah.
But
yeah.
I often wonder about
yeah, you're right. I mean, they should, obviously. And I think in some places they do. We're all meant to be trained in communication skills, but it's very generic, you know. And actually, by the time they train most people, you know, they've already there, really. You're not going to teach them to change their style. But you're right. And I think this is often handled very badly, sadly. In a busy, rushed clinic where people don't often, you know, maybe the clinician doesn't pick up how devastated somebody is by this. I don't know. But I think it is fairly typical that is what has happened. And also that, you know, at that point people will say, well, what can I do? You know, should I do this or should I not do that? And that's where quite a lot of information can be imparted at that point about really just getting on with normal life. I mean, I can remember seeing a lady who'd been told she couldn't go to New York for her daughter's wedding because she'd just been diagnosed with CLL. And I said, nonsense, go. you know what? There's nothing really that you can or can't do at this stage. You just should be carrying on as normal. Some people are lucky, they cope with this information well, they learn to park it somewhere, just bring it out when they go for a clinic review. Others are absolutely handicapped by this information and are unable to sort of function normally. So there's a big range, and we need, as clinicians, to recognise that and to be able to respond appropriately and make sure that people who need it get the right sort of counselling and advice. Because, what the last thing you want to do is see somebody's life, impaired for a decade when you're not going to be doing anything for them. They could have just been getting on with entirely normal life. So, with the median age at 70, these people should be encouraged to spend time with their families. They can see their grandchildren. Infection, yes, we have to have a plan, but it shouldn't be so fixed in people's minds that they stop being able to do the things they enjoy. Travelling abroad, all of these things should still be undertaken. So, as I said, this monitoring is not really watch and wait, but watch and worry for most people. And for many people, this can be a very long period of watch and worry, decades. And actually they never reach that point when they need treatment. So they've been waiting all that time worrying, and it never happens. But it is difficult living with that level of uncertainty. And as I said, some of that prognostic information can help. It can guide and say, well, actually, you've probably got a 50% chance that you won't need treatment in the next 10 years, something like that. But it's not exact and precise for individual patients. So, what are we watching for? And somebody actually gave me a question, what sort of symptoms? You may have none. Actually, usually, when we're monitoring patients, typically it will be because the blood count changes, and that might be something you're entirely unaware of.
Is there actually a point in telling people about this when you're meant to go on living a normal lifestyle, there's nothing that can be done? I cannot understand why I was ever told about it.
It's a very good question. The problem is it's a duty of care. If we, unfortunately... No, I mean in terms of if the diagnosis is made and we have that diagnosis, we have a duty of care to tell patients.
So have they actually considered not telling people?
Everybody always thinks that. I think it a lot with patients. I think, I wish you'd never known about this. That would have been the best thing. But unfortunately, you can't rewind it. Once they've been told they've got an abnormal blood test, that's it. Where it can be stopped, and actually when I was talking to the GPs, I did say this, is, if you get a result back that's marginal, a lymphocyte count of 6, just repeat it. Don't do any other tests, because once you've referred it to a haematology department for specialist investigations, they'll make the diagnosis. The GP will have a report on a blood film which says that this patient's got leukemia. Now, they can't then, legally or morally or ethically fail to tell a patient that they've got that result. And actually, I have seen someone in clinic who had that, and the GP didn't do anything about it for a couple of years, and then it all emerged. And they took the GP to court. Because he had failed to give them that information at that time. So it is a duty of care. It would be legally actionable if you had not been told. I agree that from the sort of management point of view, it would be nice not to know, but you really can't. The only way it can be cut off at the earliest stage really is by the doctors not doing the test, just saying, just noting that the lymphocyte count was a little bit high, but repeat. And often you'll look back, and that has been the case in patients. They've had a mildly increased lymphocyte count for a long, long time, and nobody's ever investigated that further, and that's probably a good thing. They may have had 10 years without knowing about it. But once you've got a diagnosis recorded on a sheet of paper, you cannot fail to do something about it. But what are we waiting for? Somebody asked that question. As I said, often nothing. You may not get any symptoms at all that are related to progression. It may simply be that we notice when we're seeing you that there's a general trend in the blood counts which are suggesting that moving towards treatment. Sometimes people will get enlarging lymph nodes and we'll notice that, but you've got to be a little bit wary of that because they fluctuate, they come and go, they go up and down. So, and so does the blood count. sometimes. So you wouldn't jump in the first time the white count goes up a little bit. And I think it's really important to provide whatever you can in terms of lifestyle advice and emotional support, because this is such a difficult and confusing time for people. And it's just critical that people are able to get on with a normal life. I usually say, you go away and just live normally. Let me worry about whether there's anything we need to do about the CLL. That's my responsibility. You go away and enjoy life. And it does get easier over time. And I'm sure people in the room who may have been recently diagnosed, hopefully you'll be able to talk to other people in the room who've had this disease for a long time and be reassured that actually you do learn a way of coping and dealing with it remarkably. Infections, I just want to say, they are common. They're mainly bacterial respiratory tract. It's really important that people look out for lower respiratory symptoms which need and chronic sinusitis, so need a more proactive approach from the GPs. And I always write that in the first letter to the GP. I say, please, this patient is more likely to need antibiotics if they get a lower respiratory infection. I mean, just a cold or something is probably not. And also just to warn people about shingles. Shingles, of course, can occur in any perfectly healthy people, but it is more common in patients who have CLL. And if you notice the symptoms and signs of that early, then getting early active treatment can be helpful. Some of the nastier infections are rare in patients who've not received treatment, and they're usually related to some of the treatments we give and whether or not patients get neutropenic or not. But really getting in there early, treating effectively. So it's against the sort of paradigm that's followed by general practice, quite appropriately, that you just leave it and wait for it to get better. You just need to not sit on these things. I always advise that the GP gives these immunisation. I think at least it's also at that first diagnostic appointment, it's something you can say, well, actually you can do this, and that's useful, and it makes people feel that something can be done at that stage to reduce the risk of infections. We still see quite a lot of pneumococcus and pneumococcus influenzae.
Can I just ask you about that? I've been told by another clinician that all CLL patients who have two different types of pneumonia vaccination, was that my GP, or the nurse was doing something else, and said, no, we do I can't pronounce it again, pneumococcus.
Well, yeah, pneumococcus is the infection. There are two vaccines. One is Pneumovax, and one is Prevnar.
Okay.
And
Should we have
the one, no, you only need to have one, and it is better to have Prevnar. Now, the one that is usually given is Pneumovax, because it's the older one and it's cheaper. Prevnar is usually only given to children. But when I write in the letters to the GP, I always ask them specifically to use Prevnar. None of these vaccines work as well in CLL because obviously they're relying on the same cells that are faulty to actually induce an immune response to the vaccine. So they don't work as well, but they probably do afford some protection, and they're not harmful, so it's beneficial to have them. What you shouldn't receive are live vaccines, and that's partly because we really don't have good evidence of how safe live vaccines are for patients with CLL. There are not very many live vaccines, but importantly, there is one against shingles, and that will often be offered to patients over the age of 70 at the same time as their annual flu, and it's really important that you don't get that, because I have actually seen somebody get a very, very nasty disseminated zoster from that vaccine. So, I mean, I don't think it would happen often, but the fact that it could happen is sufficient to warn. Yeah.
I've already been given the Pneumovax.
Yeah.
And somewhere on the forums it suggests that you should wait a year and then ask to have the Prevnar. Would you agree with that?
Well, yeah, I don't know. Is the true answer. You may have had a very good response to the pneumococcus. We don't typically check people for an antibody response, but you could ask them to do so. or you could have the Prevnar. It wouldn't really, as I said, it's not unsafe to you. It may not be necessary.
Should the pneumonia immunisation be an annual?
No, the pneumonia lasts, and in fact the Prevnar lasts probably 10 years. I mean, it's a good vaccine, and Hib for 5. It's only flu that's every year, and that's partly because it's a different vaccine every year, because there are so many flu strains. There's only one pneumococcus, but there are thousands of flu, and each year they construct a vaccine which sort of reflects the prevalent flu viruses that are around. And actually over time, if you're having it every year, you're constantly building up a much bigger repertoire of protection, because these are, unlike immunoglobulin, which is sometimes used to protect people from infection, that only has a temporary effect. This should have a permanent effect. You should, any response you mount to it should be, permanent for you. So, supportive care. Sorry, we're moving rather more slowly than I thought, but just hopefully your clinical team is supportive, and if the doctor isn't, then your clinical nurse specialist surely will be. And you should be given access to patient information. You should be given written information as is displayed here, but also websites and online information. Please be wary of online access to information. Some people can become totally obsessed with this, much to their detriment, really. It can be quite harmful becoming obsessed to chat rooms and online information, and some of it is helpful, but an awful lot of it isn't. And we actually give people, and I think it's listed in the patient information, websites that are reliable that you could get good information from. And then, psychological and social support will be available in all the hospitals that you're being seen in. And it may be that you need to flag up to the doctors that you need that you need some specialist input. And then, of course, you've got patient support groups like this, which don't suit everybody, but for some can be an absolute lifeline. Talking to other patients who've gone through the same experience can be really encouraging. Sometimes online it's not, because you only get people who've had bad experiences. And also for many, there are a lot of people who are diagnosed with CLL who are still working. Some of them are self-employed. There are all sorts of anxieties around finances. And there are good places to access some of that. And somebody mentioned about accessing support for carers. And again, patient support groups will often have information for carers, but also Macmillan and other PALS groups in, the patient liaison services in the hospitals will have information about where you can get money to, the income from social services for those who are caring for patients. So there are all sorts of things that can help with practical issues. Please don't be afraid to raise that if that is a concern for you. It may not be that you're asked specifically about it, so it sometimes will come back to you to actually say, look, I'm really struggling with this, or I have a real problem paying for the car park. Let people know, because there's nearly always something that can be done about it. Indications for treatment, as I said, there are strict criteria. Here they are. I'm not going to read them out, but this is the initiation of treatment, and it's just important that it's not just done because you've got leukemia, it's done because you've got leukemia that is active and causing problems or symptoms. And the other important thing is that in the guidelines, we only recommend that this test is done in someone who needs treatment, because at the moment this is a test which particularly helps us to choose which treatment to give. Otherwise, it can just be a worrying thing if it's found. And sometimes it disappears. I've had patients, we do tend to track this on a research basis, and it sometimes fluctuates, and it can sometimes even disappear. I'm sure it's still there at a very low level, but it may not be there as high. But it's not in itself an indication to have treatment. It's there as a guide to which treatment you choose. So this is how things have changed. Don't get too taken up with this, but it was 1961 that chlorambucil was first used to treat CLL, and since then there's been a sort of explosion of treatments. Took a long time to take off, but in the 1980s we got fludarabine and some other purine analogues. In the 1990s were the first combinations of the purine analogues with alkylating agents. And then really since the beginning of this century, we've had chemoimmunotherapy, which means adding an antibody. And in this case, the antibody is rituximab. And there have been a number of combinations here. And it's since the introduction of this, the chemoimmunotherapy, the antibodies, that things have changed. That there's been a step change in outcome for patients in terms of improving survival. And then, we've got all these chemo-free therapies now, which we're trying to explore and understand how they fit with what we already know. So in terms of assessing a patient who needs treatment, so you've got beyond the point of meeting the criteria for treatment, you assess there are lots of things to look at. You've got to look at the disease, you've got to look at how fit people are, and there are different ways of doing that, what their age is, anticipate what sort of toxicity the treatment you're thinking about might have, what sort of supportive care you might need to give with that treatment, how it's all going to affect somebody's quality of life, and of course patient preference. So patients will have a view on this, often will have read all the information, they won't want something, they might want something else. But at the end you've got to construct a goal of treatment for that individual patient, which takes into account all of these factors. So say we have, these are 3 gentlemen over the age of 65 coming into the clinic. So this one, I think you'd think, yeah, it's pretty fit, this guy. Wouldn't have much hesitation giving him FCR, say, whatever these are, sort of top therapy. Now, this one comes in, actually I don't see many patients in this category because they tend not to get the tertiary referrals, but if I were, I'd think it was pretty sporting to go for FCR or something like that. I'd be thinking much more of a tailored therapy that was going to not have a deleterious effect on his quality of life, but give a good response. This one is a bit more tricky. Because he looks quite fit, doesn't he? I mean, he's not undressed like this one, but he looks as if he still might work out in the gym and be in pretty good shape. But then, you have to look beyond that, and when you talk to him, you find that actually he's had high blood pressure for a long time. When you check his renal function, it's actually not as good as you would expect. And so these categories were derived from the Germans' go-go, so-go. And this is my own category, which is the not-so-go-go. So it's the one who comes in and you think you're perhaps going to have to modify your treatment decision or treatment plan based on the fact that he has some significant comorbidities. And we're not very good at assessing comorbidities. There are lots of ways of doing it. I love this one because there is apparently a locomotion score that you can do on patients, and I thought this was quite a good illustration for locomotion scores. I'm not sure how that would influence my decision about treating any of these patients, but actually the only really robust way is to have a team of about 10 or 12 people, multidisciplinary team, who can take all day to do a comprehensive assessment, and this is what the geriatricians do. We sort of compromise and use something called the Sears score, which is a comorbidity score, which is still manageable to do in a clinic in 10 minutes. Would actually work for you, and it's what's been used in a lot of the trials, and they take an arbitrary cutoff here at around 6, and under 6 patients are regarded as fit, over 6 less so, and that has been used as a cutoff in some of the clinical trials, and you may be aware of that if you've been in these studies, and it's certainly used to sort of analyse some of the data. So you may find somebody filling out a little score sheet on you, and it's not brilliant. All of these things are flawed, I'm afraid, and this one actually you can manipulate the data to your advantage, because you can score things. If you need somebody to have a slightly higher score, then their poor vision and their poor hearing can all count. If it's really critical, you know, things that probably don't have an influence, in other words. But the most important things are cardiac, respiratory, and renal. And if people have any sort of compromise in those particular organ systems, then that will have an effect on treatment choice. Whereas I think...
Sorry, can I ask you, is there any evidence for that statement?
Sorry, for?
The statement you just made, is there any evidence?
For which statement? The Sears score or?
Well, there's a number of things here. One is the scoring system.
Yeah.
And you made a statement just now that
We can't hear.
Yeah.
sorry, the one, the people, patients regarding it as unfit on the scoring system,
Yeah.
probably won't do so well. Is there any evidence of that?
Sorry, won't do so well. What it is that it's about what treatment they might be able to tolerate more than, but that has, and I will show you something which is evidence that that matters. But the scores, as I said, none of them are perfect, but they do give some sort of guidance about what a person's function is, and I'll show you why that matters. But sorry, you're saying, is there evidence? There is a lot of evidence. I mean, all these scores that have been developed. Most of them come from a geriatric background, if you like. So a lot of work has been done on this in the geriatric community, but it's also quite a lot of work now has been done in cancer, not just in CLL, but in other cancers too.
Can you? Yes, you hear me. Right. But you said yourself that the scoring system was a bit rough and ready.
It is slightly, yes.
It seems to me that, I mean, with hundreds of thousands of people just in this country with CLL and millions in the Western world, possibly,
Yeah.
it's a sort of statistician's dream almost.
Yeah, sure.
There must be a lot of characteristics that patients have, some which are recognised in the scoring system you've talked about, but also other characteristics that perhaps haven't been considered. And with those characteristics, you could match them with performance and come up with possibly a lot more information about how people will manage.
Sure. No, I think you're absolutely right. We'd love to collect that data more accurately. I mean, that scoring system, we would only do it at a time when somebody needed treatment. So we wouldn't collect it on all patients necessarily, because the time when it's really pertinent is at the time you're going to give treatment. But I think, you know, what's important to remember, I mean, we've got a lot of young people in this room, but actually the median age of diagnosis is 72, and that means, you know, 2/3 of the patients are over 65. So looking at those over 65-year-olds is entirely relevant because it represents the majority of patients with CLL. And this is data that shows that actually, if you look at CLL patients, nearly half of them have a major comorbidity, such as a heart disease, which might make delivering treatment difficult. So we do have quite a lot of data based on CLL populations. This was on several thousand patients from the Mayo Clinic in the States, and only 10% of these patients had no comorbidity at all. So we do have quite a lot of collected data, but we don't have sort of global data on every single patient, because that's, you know, not reliably collected. In clinical trials it is, but that...
Just looking at the data, the age of diagnosis isn't the age at
treatment, you're absolutely right.
So
And people might move from here into here, and very often will do. And obviously things will change, which is why, you know, a comorbidity index, for example, at diagnosis may be totally obsolete by the time a patient actually needs treatment. So these have to be done in real time. And the same with the TP53 result, for example, which may have been entirely normal at diagnosis, but isn't so at the time somebody needs treatment. So you've got to be absolutely contemporary with the this assessment. Yes?
I mean, which, oh, thank you. If you've got a disease which is in general diagnosed because somebody has some other kind of test, that must skew the data in the direction of comorbidity, mustn't it? Because almost by definition, your patients are going to be people who've got something that's led them to be tested in some way.
That is a very good point, but it's not necessarily the case. You'd be surprised how many people have blood tests as part of some other well-person check or insurance or employment when they've got no reason at all to have it done. Or they're going in to have their cataract fixed and they have a blood count. Or they're having a cholesterol done just as a routine in the clinic, and they get a blood count at the same time. So actually the majority of the people, certainly the one, often when I see people and ask them about this, why they had the test done, most of them did not have it done because they were unwell. They hadn't gone to the doctor because they were sick. It was for some other reason that they had it done. But you are right. It could be that you're monitoring somebody for something else, which is a comorbidity, and that's how it's picked up. But actually in this age group, it's fairly likely that somebody will often be on another medication for something else. And so this gentleman also asked about, do the comorbidities matter? Well, they do, but what's interesting, and I think this is not what people intuitively would think, it's not because people die from the comorbidities, they don't die from their heart disease. They do die from CLL, and they die from CLL because they're not getting decent treatment for CLL because they've got heart disease. So it's a sort of circular thing. And it's not, so it doesn't affect the PFS much, but it does affect survival. So patients with more than 2 comorbidities are not surviving as well as those who have less than that. And it's largely because the issue has been we've been unable to deliver good, effective therapy to people because of that. So what is our goal of treatment? Well, clearly we want to improve survival. We don't want people to die anymore from CLL. I work very closely with another disease called hairy cell leukemia, which is much, much rarer. And I've got to go and give a talk about that. So it's very much in the front of my mind. And in the 1980s, they published data showing that the survival was 4 years. Median survival was 4 years with that. We now have data on a large cohort of patients where the survival for these patients is the same as an age-matched population. So effectively, we've cured the disease because they're not dying from hairy cell leukemia any longer. And that's an extraordinary achievement over a few decades. And, hopefully we will be achieving the same in CLL. But we don't want to improve survival at the expense of quality of life. So maintaining quality of life is clearly critical. And that's both in the watch and wait period, but also during and after treatment. And integral to that is minimising the side effects of treatment. And it's just to set, defining treatment goals. Things have changed. It might have been all right 50 years ago to say to people, we'll give you a bit of chlorambucil, it may help you a bit, you're still going to die from CLL. Life expectancy has improved. So if we look down here in, not all of London is as good, but parts of London, if you reach the age of 65, you're expecting another couple of decades, 20 years of hopefully good quality life. And so you're seeing people, we may think that they're older, but actually they're still thinking that they're going to be around in their mid-late 80s. And we have to reflect that in the types of treatment decisions we're making.
Can I ask a question? What are the statistics for younger people?
I couldn't tell you, but obviously in some respects there's a slight reduction. I mean, in other words, if you get to 65 and you're still alive and well, then you've probably got a better incremental life expectancy than if you look at people at the age of 20, because you've got a whole load of other things they might die from Does that make sense? I'm afraid I don't have it. It's there. If you go to a website, you can find all that statistics. I've just done it really to highlight the fact that because we might think that patients with CLL are older, they are actually still expecting a lot more mileage, and you know, they quite rightly wouldn't want to be fobbed off with a sort of we don't need to do a lot about you because you're going to die anyway. Yeah, you know, which I think has sometimes been people's approach to this in the past. And what we know as well is that patients, so this is patients over the age of 65, and this is the dotted line that they should be following in terms of survival, and this is the line that they do follow if they have CLL. And so patients are, their survival is compromised by the CLL. And that's often for the reasons I showed you, that we're not giving them proper treatment. And we know that we can improve both quality of life and duration of life by giving effective therapy. And that simple sort of palliative approach is really not tenable for most patients. We've got to just think hard and work better at finding ways to treat people appropriately. And this is the quality of life data. I won't go into all the analysis, but suffice it to say that most patients who require treatment, if you quiz them closely enough, however well they think they feel, they are reporting an impairment in their quality of life. And you can change that by getting a good response to treatment, and particularly a good response to treatment which lasts. So these bars, compared with the magenta bars, this is patients who've stayed in remission as against those who achieved a remission but relapsed and needed further treatment. So getting a good remission, staying in a good remission, improves quality of life, and that should be our goal for all patients, regardless of age, regardless of their comorbidities. We just need to tailor the treatment appropriately. So that was the adding, I went back. Adding, it's not just adding years to life, but life to years. In other words, it's quality of life as well as longevity. So I think we've had quite a few questions, and I'm sorry I've gone over, despite the fact that I only had about 30 slides.
Good. Well, Claire, thank you very much indeed. That was brilliant.